afternoon, all. I'd like to, my name is Miriam Lamar. I'm the chair of the Primary Healthcare Specialist Group of the BCS. So I'm delighted to welcome you here today to talk about our topic, which is about is remote patient monitoring the future for digital primary care. So before we dive into the detail, and thank you all for being prompt in attending. I think we'll have a number of people joining us as we start. But sorry, I'm just going to have to get them in as well. So before I start, so I'm Miriam Lamar. I'm a management consultant. As I said, I'm also the chair of the Primary Healthcare Specialist Group. If I can quickly introduce you to my the speakers here today. So perhaps Vijay, could you introduce yourself first?
Yes, hello. I'm Vijay Rajput. I'm a practicing general practitioner and a clinical director for a clinical commissioning group. And in these roles, I've been involved in delivering digital technologies to support care. I look forward to sharing some international perspectives related to telehealth, delivering healthcare remotely using technology. Thank you.
So I'm doing this in the order of the speakers actually as well. So Sarah, could you, Sarah Piggott, could you introduce yourself, please?
Yep, so I'm Sarah Piggott. I'm an ICS remote care programme manager over in Staffordshire and Stoke-on-Trent, based at the University Hospital of North Midlands.
Nosheen?
Hi, my name's Nosheen. I'm a GP. I'm also the commissioning lead for cardiovascular disease in Waltham Forest, and I work as a health technology advisor and primary care innovation lead for UCL Partners.
Thank you, Nosheen. Neil?
Hi, Dr. Neil Jones, retired general practitioner, currently working in NHS Digital as clinical safety lead.
Great, thank you all so much. So I'll just quickly, assuming this will, just some housekeeping type of things to be aware of. It's great to see some people with videos on. Happy for you to have your video on if that's something you want to do, because it's nice to see faces. But if we have a problem with bandwidth, we might have to change that. If you have questions during the session, hopefully you can actually put them in the chat if that's all right. Thank you very much. If anybody's got a burning question during it, please raise your hand, and you do that through the reactions piece. You'll see a raise hand just under there as well. So in terms of this, you'll have probably noticed that we're recording it. The aim behind the recording is that it will after the event, we'll put it up onto YouTube so that it's accessible to yourselves, but also to others, because a few people have said they couldn't attend, but they're very interested to see what the discussion and catch up with it afterwards. So there's that. I've said questions in the chat. Please be on mute while people are talking, where we've talked about video. Somebody's request that live transcription be enabled for the meeting. I don't know how that works on Zoom. So are people comfortable that I say yes to that? I'm sure it'll be helpful. Okay. I'll put it on. I've never seen that message come up before, so I'll put it on if you're okay. Okay, we are hoping to have this as reasonably interactive as well. So we'll be really grateful for any questions that you've got to ask as we go through. The organization of the the meeting is that basically Vijay will speak first about what he's discovered as part of his research. If there's time, we will take perhaps one question at that point, and then that'll be followed by Sarah to talk about her experiences and what she's learned as a result of the work that she's been doing, then Nosheen and Neil. And then at the end of it, we will be having a Q&A session and hopefully a bit of a discussion around what's come through. Nosheen has to leave us at 1:45 just before we end. So if anything, just to be aware of that. So I thought I should probably say, we should really have a bit of a sales pitch about the Primary Healthcare Specialist Group. I don't know who here, on this call are actually members. If you are, maybe you'd raise your hand. It would be quite interesting. Now Griselda's raising her hand. I can see some of my colleagues from the committee are on here, but it would be interesting to see how many are actually members. If you're not, we'd like to encourage people to join and to take part in sort of events like this, because we are a very active group. We're always interested in trying to keep up to date as to what are the issues that people want us to be providing comment on, or bringing speakers together in order to be able to start discussions around it. The group's been going for a long time. It's been going for about 40 years. Some of the people in the group have been heavily involved since the beginning of health informatics and have a lot of experience to share. So it's a very interesting group, and we, as I said, we run quite a lot of events, this being one, and we've got our conference coming up in November as well, which we hope will be face-to-face, given everything that's going on. And the other thing to say is we're all volunteers, so we're all putting our time in to sort of and make this happen. The aim of the BCS is to make IT good for society, and we want to make it good for primary care. So that's what we're about here. So I think without further ado, I'll hand over to Vijay, and he's going to start. And Vijay, you're going to do yours as a recording of a video, but obviously Vijay is here to answer any questions. Yeah. So I'll hand over to you. I'll stop sharing.
Thank you, Miriam. I'm just going to share a recording of the presentation, and I'll do that now. Hopefully it'll all work fine. Just do this.
Hello, I am Vijay Rajput, a general practitioner in England and a clinical director within our NHS Clinical Commissioning Group. The International Medical Informatics Association, IMIA, has a telehealth working group which is made up of more than 100 members from across the globe. It includes researchers, practitioners, academics, and entrepreneurs. I will present a summary of recent collaborative research for which I am co-author from our IMIA working group, focusing on the COVID-19 pandemic, ethics, and enabling health equity. I'll describe the approach and outcomes in the first paper, which highlights how we can share learning internationally. I'll then provide a summary from the other two papers. The practitioner perspectives reflected in these papers are responses from working group members and do not represent a comprehensive picture of global practice. The first publication I will describe compares telehealth responses to COVID-19 across 9 countries, published last year. While telehealth and other virtual care tools existed pre-COVID, the need for public health practices such as physical distancing and a desire to keep people out of high-risk settings, such as hospitals, accelerated the adoption of telehealth. Telehealth implementation is a complex system-based behavior. Our overall objective is to develop a health system-based framework for telehealth implementation to support critical response. We sought responses from members of the IMIA working group on their practices and perception of telehealth during the pandemic in their respective countries. The representatives from the 10 countries are listed here. They have different health system delivery models and perspectives, including variations in success in response to COVID-19. The question posed to the members was, describe how telemedicine was used in your country in response to the COVID-19 pandemic, including pros and cons of telemedicine usage. Our analysis identified 6 themes that describe telehealth experiences and the lessons learned from implementation, listed here. I'll highlight a few quotes relating to each theme. The government of India issued an advisory for those with chronic conditions to avoid visits to healthcare facilities for non-emergency consultations. These disruptions led to accelerated release of the telemedicine practice guidelines in 2020, which provides a legal framework for delivery of healthcare remotely by the Board of Governors in supersession of the Medical Council of India. In Brazil, there is legal authorization of telemedicine by federal law in 2020. Several practices have been permitted for remote consultations and prescriptions, complying to some requirements to provide security to the process and safety for the patients. The Canadian British Columbia Ministry of Health, in association with a group of health organisations, set up a network of virtual care to support clinician-to-clinician and clinician-to-patient telehealth services, collectively named as Real-Time Virtual Support Services. In the UK, licenses for online consultation software are purchased from a list of accredited suppliers via a dynamic purchasing system. The My Health Sri Lanka application was made to empower citizens with knowledge for decision making and to enable collaboration between governments and private sectors. In the USA, there was a powerful bilingual system to help the citizens of Arizona, especially the more vulnerable and underserved populations, to successfully cope with the pandemic. Brazil highlights the benefits of population reach. The Government of India has included telemedicine as one of the key building blocks proposed in the National Digital Health Mission. Healthcare services had to switch delivery from in-person to remote contact rapidly. The Telemedicine Society of India, in partnership with the Digital Health India Association, pulled a team of volunteer resource persons who designed an online trained to practice telemedicine certificate course. In the UK, volunteers had been engaged supporting over 2 million people at risk, such as delivering food and medicines, driving patients to appointments, and phone calls for the isolated. They were managed through a dedicated mobile app. The Ministry of Health and Welfare of the Government of India is implementing an e-health project including telemedicine on the National Medical College Network for interlinking the medical colleges across the country. The Brazilian telemedicine, telehealth, and health informatics societies have been promoting actions through online seminars and courses throughout the country. The 6 themes just described highlight that telehealth delivery is a complex socio-technological endeavour with multiple components. To provide a system framing for telehealth implementation in times of critical response, we mapped our themes just outlined to the WHO system framework. This is shown in Table 1, and I will highlight 3 rows as examples. Leadership and governance highlights the role of policymakers, organisations, patients, caregivers, and providers. Health workforce highlights the role of virtual care tools enabling support for the workforce and facilitating community involvement and support. Medical products, vaccines, and technologies highlights that systems need to ensure their processes continue, such as medication supply and home supports, but also address the need to ensure digital safety standards are met. While our country is represented by a diversity of geographical, cultural, and socio-economic contexts, we still found many similarities related to telehealth use during the pandemic. Legal or regulatory issues were also experienced by all countries, and government flexibility occurred despite the different healthcare system delivery models. However, we cannot be so fixated on agile and rapid implementation that we ignore the need for interoperable standards, privacy, security aspects of informatics-driven systems. We need to ensure that telehealth delivery is done so it benefits all citizens, and patient and public engagement is necessary for any technological initiative. The main contribution from this paper is a systems framework for telehealth implementation that provides guidance for the design and implementation of telehealth tools. next paper, published in 2020, is entitled Ethics in Telehealth, Comparison between Guidelines and Practice-Based Experience, the Case for Learning Health Systems. This paper compares telehealth responses across 9 countries. This figure illustrates one framework for ethical decision-making in terms of regulations, ethical principles, values, and codes of professional conduct. We developed 4 open-ended questions to compare ethical guidelines for telehealth with issues from clinical practice in different care delivery contexts. These focus on areas such as cultural differences, big data, remote practice, and special populations. Here is an example of responses to the first question. Even though telemedicine continues to expand in Sri Lanka, the National e-Health Guidelines does not have regulations on telemedicine consultations. In the absence of telehealth guidelines, the practicing physician's code of conduct is governed by routine ethical practices. In Argentina, despite the prevalence and utilization of telehealth services, there's little uniformity around the legal frameworks of ethical guidelines. This places the onus on clinicians to adopt the ethical practices on a case-by-case basis. We used the 4 questions to synthesize perspectives of telehealth practitioners and a review of telehealth ethics guidelines from 3 sources: the American Medical Association, the Health Professionals Council of South Africa, and the World Medical Association. The key findings from our work are: guidelines are more focused on the structural aspects of telehealth. Practitioner perspectives provide an important source of practice-based evidence that helps contextualize the use of telehealth in specific settings. We identified a gap between ethical guidelines and the practitioner perspectives. We suggest a learning health system approach can help us better understand how to bridge this gap. The next paper has been accepted for publication this year and is entitled Telehealth as a Means of Enabling Health Equity. The paper compares telehealth responses across 11 countries. The overarching question was, how can telehealth help design resilient and equitable global health systems? The group concluded that technology alone will not create a resilient telehealth system. Telehealth services have led to unintended consequences, including inequity issues and an increase in the digital divide. Telehealth practitioners and professionals therefore need to purposely design for inclusivity as part of broader health system goals. While our countries represented a diversity of contexts, we still found many similarities related to telehealth use during the pandemic. Some legal or regulatory issues were adapted to enable rapid implementation, but issues such as privacy, safety, and security need to be central in informatics-driven systems. Guidelines need to incorporate practitioner perspectives to contextualize the use of telehealth in specific settings. People who were able to access telehealth were often those that possessed appropriate technology and were more technically savvy. We need to ensure that telehealth delivery is done so it benefits all citizens and designed for inclusivity. We're not here to solve telehealth implementation, but rather make recommendations on how we can better enable telehealth to support care. Following our collaboration, we have initiated a telehealth guidance program for practical, easy-to-use guides. The target audience include patients and families, healthcare professionals, manufacturers, and policymakers. These will be applicable in regional settings and internationally, eventually to be published on a dedicated website. Thank you.
Thank you. That concludes my presentation.
Brilliant. Thank you so much, Vijay. That's very interesting. It's very interesting to hear what's going on internationally, isn't it? I mean, it raises a couple of questions for me. One was about what is telehealth? because I historically probably would have thought of telehealth as being more, you know, checking your blood pressure and all of the rest of it, whereas this is suggesting other things. I also think the what you were saying around the ethics would be interesting to see how that links in with what Sarah's been finding in terms of the implementation piece that she's been doing. So I think if it's a thank you so much for that. And if we move on to Sarah's presentation now, Sarah, are you available there? I will start sharing your slides. There's quite a lot of background noise there. Sarah, can you? Yeah. Can you see your slides? Are they sharing okay?
No, yeah, that's absolutely fine. Hi everyone. Yeah, I'm Sarah Piggott. I'm ICS Remote Care Programme Manager covering Staffordshire and Stoke-on-Trent. I'm actually based at the University Hospital, North Midlands, which is one of the main acute trusts in North Staffordshire. So I'm not professing I'm any expert, but what I can share today is experience that I've had over the last probably 3 or 4 years around remote care, the use of digital tools, and how it has an impact on patients, systems, and how we move forward with that. So have you got the next slide? Yeah, so the main kind of 3 kind of key areas that we've looked at the use of digital solutions, and probably picked up obviously with COVID, was around how we can support admission avoidance. And what that means is looking at is the digital solutions out there that we can use that actually will help patients to have earlier intervention rather than waiting till their subacute is actually at a point where they need to be admitted. So I can share some information about what we're doing around that. The other area which we're looking at is around planned care and that elective recovery, and how can we use digital solutions to help us around waiting lists, patient initiated follow-ups. How can we use that? And that doesn't mean just within an acute hospital, but also kind of patient management across our community, and obviously within a primary care setting as well. How we can use that as part of that whole kind of planned care agenda. And then going back as well is about how can we look at using digital solutions for early discharge and reduced length of stay. We know that really if we can get patients out sooner when it's safe to do so, it's better for the patient. If we can avoid admission and they can be cared for in their own home using digital solutions, that's got to be better as well. So I've listed just a couple of national drivers that that I'm aware of. Obviously from NHSX around the agenda around digital transformation, integrated care record, people will be aware of how we can use that, how we can get patients sharing information across different organisations, particularly for those patients with long-term conditions. Definitely around personalised care and patient choice and supported self-management, and I'll probably share experience around more of that in a test bed programme I was involved in. The other area is obviously around that operating planning, where we know we've got increasing escalations to emergency acute services, elective recovery, long COVID, and digital response to COVID. So one of the things which I don't think is, it's not just our area, where we set up some COVID virtual wards for patients as part of discharge from hospital, which were managed using OxyHealth programme and pulse oximeters. Another area was around the TOPL review. I don't know if people are familiar with that. It's quite interesting to have a look about whether we've got the right healthcare workforce ready to deliver this digital solution, digital future. And it's about how we use telehealth and other staff members to support that telehealth digital way of working. And then more recently, we've just had guidance about the virtual wards programme, which we've always had virtual wards, I believe, but actually now they're looking at using them alongside technology to supporting that admission avoidance and early discharge.
Sarah,
Yeah.
there's a bit of a boom on your microphone, I think. I don't know whether it's, I can't see where your mic is.
Is that better? Is that
Yeah,
better if I move my mic away from my mouth a little bit more?
Yeah, I think that's great.
Is that better?
Actually, that sounds better. Yeah, wonderful.
Okay.
Shall I go on to the next one?
Yes, please.
Yeah.
So my first experience has been part of a Smart With Your Heart testbed programme. This was funded through NHS. Application was submitted and was awarded 1.2 million to facilitate a testbed programme working with heart failure patients, where we know that readmission for these patients is pretty high, particularly at 30 days and 3 months. I think it's around 50% of heart failure patients will be readmitted back into hospital, not necessarily through heart failure, but often through other all-cause readmissions, just based around their vulnerability. So the main aim was obviously look at how we could use digital technology to reduce that all-cause readmission and improve patient experience. So the project lead was one of the consultants here at the University Hospital of North Midlands, but it was definitely a partnership between ourselves, our community services, GPs, we use 3 digital providers, local providers, and we also engaged with around the evaluation around the universities. The programme had 4 key principles, and I think it's these principles that have probably I've created some legacy in how I've moved. Some have learned from this and how we can use that in that remote care monitoring, which is about how can we use digital tools for earlier intervention, so it flags up earlier that you're not waiting for the person to have a flare-up, a heart failure flare-up, or whatever that flare-up may be that will bring them into hospital. Education, using digital, how can we improve patients' education to help to self-manage and feel confident about their condition. Engagement in community and voluntary sector social aspects. So one of the key things that we looked at here was how we linked in with social prescribers within primary care, because one of the key factors we noticed that a lot of some of our heart failure patients had other issues other than health and clinical. They were more social, that actually could have an impact on their health. And the other principle was around the use of a telehealth coordinator who would help to monitor some of this, but then have a very defined script to support of knowing where to go to get response back, depending on what the patient had recorded. So the digital technology was one was very simple SMS text basing service, which some of you might have used or are familiar with, which is Flow. It's got algorithms within the protocol that you set up. So we had 3-month based protocols with patients who would have over the course of the 3 months a welcome message. Hi, I'm Flo, how are you feeling today? And that protocol was based around their symptom checker, but general, how are they feeling that day, whether they felt worse, same or better. The other tool that we had was a web-based education library, which allowed us to provide clinically prescribed information for the patient to really understand about what their condition was. And we did have a mixture on the programme of newly diagnosed heart failure patients and those patients that had heart failure for some years. And within that library, we had, I think there was about 150 different types of information depending on the patient, whether they're newly diagnosed, whether they were existing, whether it was some palliative care information. There was little different videos about helping to reduce anxiety and breathing techniques. There was a whole host of information, and some of that was supported through the Pumping Marvellous charitable fund and through links into the British Heart Foundation. The third digital tool, which we didn't manage really to get off the ground as much as what we wanted to, was a social prescribing app, and this was where all social, voluntary sector, community sector organisations were on an app, and you could refer a patient as a clinician to that voluntary group, to access, and you could track whether the patient went and also what kind of feedback they got from that. And some of it was basic around either financial, monitoring, mental health. And these were some of the things that we wanted to see how would have an impact on that patient coming back into an acute trust. Yeah, next slide. Yeah, so the findings. So this went on. The findings, and when we had to draw it to a close a little bit sooner than what we thought, because it was when we first went into COVID and we were restricted to accessing patients. So this we had to minimise that contact, and we finalised our patient engagement probably in March 2020, March to April 2020, and then we monitored those patients that we recruited in that period for another 3 months to see if the digital applications worked. What we found, by a combination of the digital tools and the telehealth, there was a 50% risk reduction in all-cause readmissions at 3 months following that discharge. And I think this is from what experience and hearing from the telehealth, a lot of patients felt, one, they had the right information, but also the telehealth role offered them reassurance that somebody was monitoring them alongside the text messaging, so they didn't feel quite vulnerable or anxious. They knew there was some kind of contact there, that somebody was keeping an eye on them over the 3 months, which we could quite easily do. So the telehealth would have a dashboard, and they could see what information people were reading, whether they'd read it or not, and also responses back from the flow text messaging. So if the patient had reported that they didn't feel well, or on their symptom checker they were red, the telehealth would follow that up and actually unpick some of the reasons why they didn't feel right that day. Some of it meant having a conversation with their GP, some of it was social issues, and some of it was just an event that might have happened. So I know that we had one gentleman who'd had a bereavement, so actually he was okay clinically around his heart failure. He was just kind of low mood, and we did ask if he needed any support around counselling and those kind of things. But we one of the not only from that reassurance is the patient confidence in being able to manage their condition a lot better than what they had done before, and bearing in mind the patient's average age was 73. So both what we found was that patients use both their texting and the web base. That restricted us to a certain degree on who we actually engaged in the program, because that was one of the criteria, that they could use texting and the web based. In hindsight, it'd be interesting to see what that looked like if we were just to use the texting with the coordinator, but for this project we used both digital tools, and the average age, as I say, was 73. We did have some older using both of those. Patients reported that the digital tools are very easy to use. The SMS texting is very basic text messaging, and we had the ability to provide earlier support and access to community and primary care services. So more recently, I've been involved, based on my experience of using Smart With Your Heart, as part of an ICS remote care agenda. So we've recently set up a remote care board that covers the whole of Staffordshire and Stoke-on-Trent. We've got kind of 4 kind of key areas around that programme. One's around virtual ward, which is quite big, massive area, and other areas around care homes and impact on primary care and acute services. The other is around urgent care response, and this is where we have in Staffordshire a community rapid intervention service, which is the team go out to patients which they have referrals from the GP, care homes, and they have the ability to treat patients in their own home, whether that's intravenous antibiotics or some kind of monitoring, and they can provide that response within 2 hours as an alternative of coming into the hospital. We are just reviewing that service and looking at how that service also links with virtual wards and long-term conditions, and it has recently just from January extended to across the whole of the county, across Staffordshire and Stoke-on-Trent. The other kind of key area, can you just go back, sorry. Yeah, so the other key area is around long-term conditions and remote monitoring. If I can just go back up to the virtual wards, we've just had notification, probably I think it was about February time, where the government are looking at rolling out, they're looking that we as Staffordshire, we have 40 to 50 virtual ward beds available per 100,000 population, which means in Staffordshire we are looking to set up 469 virtual ward beds, and which will enable us to have a look at what that pathway looks like from a step up point of view and a step down. The criteria is very clear that they're looking at technology, care in the home, but also that relationship with that continual self-monitoring. It's quite early days. We do have to provide a submission at the end of April of what we intend to spend our 3.9 million on, but a key element of the step up and step down is digital tools, and we are working with our digital colleagues to work that through. At the moment we're still at the clinical stage, so we look as if we're going to have 4 different types of virtual wards. One's general medicine, one's heart failure, one will be respiratory, which is a COPD virtual ward, and the last one is frailty. So the frailty one will be where we've got multiple comorbidities, but mainly looking at those frailty patients that are moderate, who are on the early decline as a frailty patient, and we've already just started to look at introducing with these patients sensors and wearables in the home, so we can monitor what their behaviour and health is like, so you can get a sense of their blood pressure. So we're using that with a telehealth for our frailty patients at the moment, with a very small cohort which we're looking to extend for frailty, and that's working really well. So you can see we have a baseline for those patients, and then any kind of flare-ups or a change in behaviour, which often is usually a subacute, either a UTI or a chest infection or some kind of infection that will bring the patient into hospital. But if we can avoid doing that, we're providing those patients will go onto a virtual ward for a period of time while they are supported either through a gen med route or through a more specialised route. The other area is around our community rapid intervention service that I mentioned, who are going out to provide treatment to patients, but those patients that need further monitoring also will go on to a virtual ward, so that we have a general med ward that patients are stepped up into, and we're just looking at how we can do a step down into that general meds ward as well. The other area which I mentioned, we're launching, or the soft launch on the 4th of April, is a COPD virtual ward, which will be a step down from our early discharge team, where patients will be, we're looking at patients using a COPD Predict app with a spirometer and pulse oximeter combined, and the patient can self-monitor themselves. It has a dashboard the patient can see, but we'll also have telehealth support to encourage the patient to keep an eye on the patient, as well as having some clinical nurse specialists as well with that. So that's taking place from the 4th of April, and what the app can do is indicate if the patient's going to have a flare-up. So again, you're intervening early with antibiotics, oxygen, or whatever it needs to be. The long-term condition, which is really interesting, which is particularly for those patients who've got multiple comorbidities, about how do we engage all the different, I'm going to cough, sorry, just bear with me. But how do we engage all the relevant health professionals that are involved with that patient? So we have got some challenges, and we are looking at that at the moment around that long-term conditions and remote monitoring. Next. So this is the draft structure that we've got at the moment. So we've got a programme board that reports into our urgent care board, mainly to the pre-hospital element of that, so we can monitor kind of any kind of front door activity. And the other is through our planned care board, which is picking up elective recovery, but also about how we can use managing waiting lists. And we've got a digital board, and those are the 4 kind of steering groups that you can see underneath there. We've just looking at commissioning a ICS remote care strategy, which hopefully will start to pull some of this together and give some direction of travel for us as well. So I think we've got quite a good idea what we want to be doing, but it's actually trying to define that and actually consolidate some of that as well. Because what we've found over the last 6 months is there's quite a lot of digital opportunities where professionals are buying the digital tool, but actually we're then searching of where it would fit with the clinical need, and we've started to flip that more on its head, that actually it's so important that we actually identify the clinical need, the clinical issue, and then look what the digital solution needs to be. And that wasn't quite happening before, but hopefully going forward it will get better, and we've started to have a look at that. And that engages, when I talk about clinical, it's not just the consultants within the hospital setting, it is a community and with our primary care colleagues as well. So that's where I'm at the moment in Staffordshire and Stoke-on-Trent. I don't know if anybody's got any questions at this stage, or we're going to leave those for the end.
I think at this stage we'll leave them until the end, if that's all right. Sarah, thank you so much for that. It was really interesting to hear about your experiences, and I'd be interested in the results, and it would be interesting to examine if that impacted on the calls in the GP surgeries as well. So if I'm going to introduce ask Nosheen to start, but if you could just bear with me 2 seconds while I just get her slides up, because I think she's having some technical issues at her end. So bear with me 2 secs, and then we can start that. now share, sorry, forgive me. And then so can you see the screen?
Yes.
Great. Okay, Noshina, I'll leave it to you.
Thank you. And yeah, great hearing from you, Sarah. A lot of what you mentioned will overlap in what we do at UCL Partners. So as I mentioned at the start, I'm a GP by background, but also work as a health technology advisor in specialising in primary care for UCL Partners. Next slide. Ooh. So for me, I often get asked by a lot of primary care physicians who perhaps aren't so digitally orientated, or perhaps don't have an interest, why it's important for them. And the reason why I would say it's really important for everyone in primary care to understand digital technology and tools is because as clinicians, we are the ones using the tools and actually understanding whether they benefit our patients or not, and whether they reduce workflow for us and improving efficiencies. And if we aren't able to understand the technology, we're not able to have those conversations with the commissioners and the companies themselves about what is it that is needed, and what are the outcomes that we want from the tool. So as Sarah mentioned, making sure our clinical needs are met first, rather than the tool being implemented for the sake of digital transformation. Next slide. So what is UCL Partners? It's an academic health science network, and there's 15 across England, and they were established in 2013 by NHS England for the very reason to help spread innovation at pace and scale through the NHS. UCL Partners is based in London, in North London, and we cover 3 ICSs: North East London, North Central, Mid and South Essex. Next slide. And again. So part of the remit of an academic health science network is to help spread the adoption of national products, which are commissioned by NHS England, and they help to improve health, drive down costs and stimulate growth. The national products come out every year, and they're nice approved products, whether they be sort of med technology or pharmaceutical products and drugs, and we help sort of implement them and liaise with our stakeholders about their pathway, about the pathway transformation for those. Next slide. So in terms of what we do, we have a lot of companies. We have 2 sections to our offering. We offer a NHS sort of service, and also a service to our suppliers, entrepreneurs and companies and digital companies. And what we do is we assess them for their market readiness. So we help sort of develop any sort of trials, prototypes, and make sure they're clinically efficient. We help with clinical validation, whether that's gathering data for health economics, understanding its feasibility of the product, gaining test beds for their digital innovation, and helping with research. But then towards the other end of the scale, we can help with market research, looking at other competitors, what the NHS need is, getting case studies together, getting pilots sorted, and then right at the far end, once we have a product that is digitally mature, has an understanding, has a value for the NHS, to help sort of broker those conversations in the NHS, to help scale an implementation of that tool. So there's a pathway of due diligence that we undertake for the companies that we work with, and again, we communicate these between the AHSNs to make sure that we're not duplicating the work we're doing with the companies. Next slide. And again, so again, just looking at the 3 pillars, making sure a product is clinically and effective, and it's safe to use for the NHS. And this is more relevant with a lot of the AI tools and artificial intelligence tools that are coming out, making sure they are clinically valid, and we're not getting sort of tools that are being implemented which aren't giving us the correct information. And there's a lot coming out towards AI at the moment, making sure it's cost saving or has a a budget impact model that is appropriate for the NHS. We don't want a digital tool that's going to cost 5 times what we're currently spending, and making sure they have relevant case studies and NHS reference sites, because that's always useful to know where it's worked before we help spread and adopt it. So again, the process of implementation: what is the problem, how many people does it affect, how it can be solved, how much does it cost, and how can we monitor, evaluate outcomes. And this is pretty much what all ICS's commissioners are looking at. Next slide. So again, there's always going to be barriers to implementing technology, and what we've found is a lot of it might be budget related, but we are getting a lot of funding from NHS England and NHSX for some of this work. Like Sarah mentioned in her talk, if it doesn't fit into a current pathway, you end up having to redesign everything just for the sake of the technology. And what you want is a tool that's going to fit in seamlessly to what you already have or what you're already creating. Not having a buy-in from stakeholders or end users, again, really important we have primary care on board with the technology we're using. Otherwise, it's just another button on your desktop and you're not going to use it. Data sharing and information governance, and I know we're hearing from Neil shortly on from NHS Digital regarding that. Transfer of workload. Sometimes technology just shifts the workload from one clinician to another, whether it be from GPs to nurses, and are we actually making those workforce savings or efficiencies? And behavioural change, just making sure that we're taking everybody on a journey with us, and there's a process of change management whenever you implement a digital tool. Next slide. So again, what I mentioned previously, making sure you take everyone on that journey. And so change management is really important to have side by side implementing digital tools in primary care. And there's a lot out there that can be utilised. A lot of consultancies in London, we're using sort of Redmore Health or NEL Consulting, which can help sort of support your CCG, PCN or ICS along that journey. Next slide. And again. So just to give you a bit of a background on the work that's been done at UCL Partners. So working within the proactive care team, we've established proactive care frameworks, which are based around long-term conditions in primary care to support a lot of the backlog that was created throughout the pandemic. So we found that a lot of the long-term reviews for COPD, asthma, cardiovascular disease, they weren't being undertaken because it wasn't a priority, and these patients were often left behind. So what the real world, what the proactive care frameworks have done, have designed a process whereby we can help utilize the wider workforce, help patients and support them in self-management, as well as using digital innovation to help address those long-term conditions. Next slide. And what it's based around is risk stratification of those conditions, whether it's hypertension or atrial fibrillation or COPD. The risk stratification used a digital tool, which was creating some of those priority areas and allowing clinicians to see on their system, whether it's EMIS or System 1 or Vision, understanding what patients need to be seen sooner because they're more at risk, prioritising those groups and then optimising their care through self-management, clinical management and personalisation. So the conditions that were covered were atrial fibrillation, blood pressure, hypertension, cholesterol, diabetes, asthma and COPD. Next slide. And just an overview, and this is an example slide, and we've got all the material on the UCLP website, but again, it would have the healthcare assistants or wellbeing coaches and other trained staff understanding and gathering that data from the patient, whether it's self-management, behaviour changes, getting the up-to-date blood pressure, weight, smoking status to enable you to do the review. So that was that information gathering exercise. The patients were then stratified according to their condition, and then a clinician, whether it's a clinical pharmacist in your practice or a GP or a specialist nurse, would then review all that information, optimize the therapy, review compliance and comorbidities, and the whole piece of work and the process around the frameworks was to enable primary care to work as more of an MDT and utilising the wider workforce, and not just having the GP do all the chronic care reviews. Next slide. So again, part of the remit and the tools that were created from the frameworks was digital tools to support remote care and self-care, alongside project management and support for clinical leaderships. And part of the digital offering was, again, tools that would help bring back that information from the patients, either through an app or a dashboard, or what we all know commonly use, AccuRx or eConsole templates. Next slide. So this is just an example of what a risk stratification search would look like for hypertension. And as you can see, we've got them in priority groups 1 to 4, 1 being the highest priority, which has got the smallest percentage of patients. And this was on a CCG level, so the numbers are higher than what would be in an individual practice. And essentially, we want to reduce the patients that are in priority group 1, and priority group 4 are the ones that need sort of an overview from a healthcare assistant regarding their condition. Next slide. So what kind of technologies would support this? Again, at UCL Partners, we support a number of tools, not just for long-term conditions, but for secondary care, community care. And one example I want to discuss today is a tool called AbTrace. AbTrace is a digital software platform that integrates into the primary care electronic health records. Next slide. So it's a monitoring tool, it's a proactive monitoring tool, and the key thing around this is it complements the proactive care frameworks quite seamlessly, because it utilises the patient data through an AI algorithm which extracts the information from your database around the patient, and it's not disease specific, it's around the patient. So care is organised around the patient rather than the patient being hypertensive and then you just do a hypertension review. If the patient, such as Peter, he's got high blood pressure, he's diabetic and he's asthmatic, why should he come to the practice 5 times to get all those monitoring pieces done? You know, get his foot check done on one occasion, see the nurse for a blood pressure check, and then see the doctor because he's asthmatic. So what the tool does, it sits on your database similar to AccuRx, like a little toolbar, and when you click it open, it will tell you what is outstanding for Peter, and that could be all booked in one day or one appointment with a nurse or a doctor straight after, so the patient's not coming back again and again. Next slide. So again, they're fully functioning with TPP and EMIS, and currently they are looking for any other sites that might be interested in joining their pilot. Next slide. And this is just an example of what's been achieved so far. So in the practice they had piloted already, they found a 30% reduction in HCA appointments, safe monitoring for CQC, so medication monitoring is also done via the tool, improved patient experience because they don't have to come for appointments, and it addresses that sustainability agenda whereby patients aren't having to travel back and forth to the practice again and again. Next slide. They are also developing a SMS and remote template monitoring tool so that can help get all the information back remotely. So Smart Respiratory is another tool that we are currently working with. And what this does is it enables patients to check their peak flow and also compliance for their asthma remotely through an app, which can be transmitted to the GP via a dashboard. Why this is important? We know that most asthma admissions into hospital get discharged, but the crucial time after discharge, that first sort of 48 hours, is when their asthma can deteriorate again and lead to readmissions. It's very difficult to get a GP appointment within that 2 days. To be honest, it's difficult to get a discharge summary within those 2 days. And so what Smart Respiratory does is aim to keep an eye and monitor that patient's peak flow during that period of time. It's also very crucial for GPs if we have patients that are on the border and we don't want to send them in, but we can't sort of constantly bring them into practice, having that remote peak flow monitoring. We do have peak flow monitors as GPs that we prescribe and we give out, but very, very rarely do patients come in with a piece of paper having sort of annotated all their peak flow. So this takes that trouble out, makes it easy for the patients and makes it easy for the GP as well. Next slide. So again, they undertook a QI project in West Herts around avoiding asthma readmissions. And it can be on the patient's phone and also a dashboard for primary care to ease monitoring post-discharge. So again, one to consider for remote monitoring, virtual wards for asthma or COPD. If anyone is interested in finding out more about Smart Respiratory, then just drop me an email. Next slide. And Aviva, I'm very, very happy about this one. I'm very proud. So this is a piece of work that we helped support after the pandemic or during the pandemic. Next slide. Aviva is a company that deals with digital diabetes education program, but also they do tier 2 and tier 3 weight management programs. Their app is in 23 different languages. They provide motivational interviewing and can facilitate remote or face-to-face appointments, and they take into account all the cultural and ethnic factors that can be quite prevalent in some areas in East London around diabetes management. And what we had a GP in East London who actually utilised the digital diabetes apps throughout COVID, where there wasn't that many face-to-face appointments, yet we were still having a large number of newly diagnosed diabetics that weren't getting that critical education at that early point. And having it in multiple languages meant that they were able to cater for the ethnic, Asian, Eastern European, and all the sort of BAME population that is prevalent in East London. And they actually went on to win an HSJ award just a couple of days ago for their partnership award with NHSX with their services around health inequalities. So that was another sort of great win for digital tools. And just briefly touching on remote monitoring. So next slide, sorry. So just touching on the last remote monitoring tool that we've been working with is a company called Healthy.io, and they have developed a remote ACR urine testing device, and this is currently being piloted again in East London, not only with diabetes but also with hypertension, as they both need annual ACR reviews that can be done remotely, or the onboarding gets done by the company. Once you highlight a patient who needs to have an ACR done, they will be contacted, sent a kit to their house, and the information will come back directly into a dashboard form that will give you all the patients that have an abnormal ACR, so you can then work towards understanding why and making clinical decisions based on that. Really important for the young diabetics who often don't engage with services as well, and often we're missing ACRs for those patients. Next slide. Again, just what we covered. It's really great for early detection of chronic kidney disease. Again, very, very important. And this is just a bit of information around the Barking and Dagenham pilot that was being undertaken, and it was match funded by NHS England. Next slide. Oh, one more digital tool. So again, atrial fibrillation, we know screening and detection for AF is quite popular. There are quite a few products out there. One of the products we worked with at UCL Partners was something called FibriCheck. But again, there's a few mentioned on there like Cardia and Xiopatch, ECG on demand. There are a lot of opportunities for, again, piloting, having test beds, but also some of the funding that is available for these projects. If that's something that your CCG are interested in, then it's please do get in touch. Next slide. So that's just a whistle-stop tour around the kind of work that is being done at UCL Partners. Like I said, we have an NHS offering and a commercial offering. And if there is anything regarding primary care innovation that you want to reach out to, or a project that you want to work on, then please do get in touch. Thank you.
Brilliant. Thank you so much, Nosheen. That was really interesting. I was particularly interested to see change management featuring so highly on there. I'm gratified to see that we're looking at what the need is before we select a tool. So I think without further ado, because we are running out of time, I'm going to hand over to Neil to respond to this. And you're all being very quiet. There aren't many questions in the chat. So could you start putting some questions in the chat and we can see which ones we can discuss when we have that time. Thank you, Neil.
Yeah, so I'll stick to a few main points that I picked up from the various presentations. And they've all been very upbeat. And I'm going to be the devil's advocate here and actually point out that everything isn't quite as rosy as you would like to believe. I mean, COVID has made a significant difference in the way we do things in the NHS. Lots of change has been made, and that change has been really very rapid. And we've seen the introduction into the market of lots of new players who aren't necessarily as experienced in dealing with the NHS and patients as some of the traditional incumbents, and haven't necessarily taken clinical safety to the same degree that you might like. Equity of access is obviously an issue. I mean, we've heard that you can have programs that cover multiple languages, but the vast majority of online offerings are only based in English, and they tend to be fairly complex questions that are not always understood by everybody to the same degree. And we've certainly had examples where people didn't understand what was going on. Simple example, you've heard about messaging patients with SMS. Well, there are significant risks around communicating with patients, which start with, have you matched the demographics between the clinical system and the messaging system accurately? Is there an automatic way of getting from NHS login into the record, or are you trying to match these things manually? And matching manually has been shown over the years to be one of the major causes of problems with delayed treatment or the wrong patient. And I'll give you an example. My mother recently needed additional care, and I've taken responsibility for communicating with the NHS for her via my mobile. But personally, I also needed to have care from the NHS using the same mobile. And I got a text message out of the blue inviting me to log on to confirm an appointment. So I did, assuming it was actually for me, because I didn't know there was one coming from my mother. So I kept putting in my username and password. And because it was my mum's account, I managed to log it out. And the system had no way for me to reset the password or communicate with anybody to get the password reset. So it became impossible to confirm the appointment that she'd been sent. So the problem is, SMS is a very short messaging system. And if you are going to send messages to the patient, you need to clearly identify who you are and what it's about, and neither of those occurred. So you would think SMS messaging would be fairly straightforward. We do it all the time, but there are significant clinical risks if you use SMS messaging into clinical systems. We've heard about the various new suppliers, and they've been working on things like video consultations and online consultations where you collect information from patients to make the practice be able to make decisions quicker. But they're also moving into the direction of automated triage through to, as we've heard, automated sort of decision trees, and even down to using what they would call AI to actually categorize the patient's symptoms. Now, these are all well and good, but the increase in complexity leads to more and more clinical safety issues that need to be reviewed. We've heard a little bit about algorithms. One of the recent ones that was collecting blood pressures from patients over a period of time miscalculated the average blood pressure reading for several thousand patients, which resulted in incorrect treatments for those patients and a huge amount of workload in correcting the error when it was spotted. So these things really do need to go through full clinical safety review. What else have we talked about this morning? Oh yes, a lot about collecting information from patients. It may be ACU, it may be blood pressures, it could be diabetic monitoring. How does that information get back into the GP system? There's been a great pressure for some of the information to flow direct into GP systems. So, for example, all of the COVID tests had to be flowed into the GP records, and the vaccinations at one point got fairly close to 1 million vaccinations a day. General practice could not have coped with manually filing 1 million vaccination records a day, so they've been automatically filed. However, now we're moving into a phase where we've got patients at risk who are starting to get COVID again, and if their results flow automatically into the patient's record, then who takes responsibility if a patient at high risk has a positive test and doesn't get advised to have the newer antiviral medications? So are we exposing the GPs to risk? And that was fine at one point, but now the world has moved on. So we need to consider how these things change. Really, I think the message is each of these new activities needs a detailed analysis of what the hazards are, what can go wrong, what is the cause of that hazard, and then how do we mitigate it, how do we reduce it to as low as possible. So everybody needs to know that if you're communicating with the patient via SMS, there are certain prerequisites that you have to do in that simple message to make sure that it's a safe communication and you don't end up with a delay to treatment because you haven't attended the appointment. So given that we really do need to have a decent period of time for conversation, and really mine was more about warnings than specific examples, I think I'll hand back so that we can all now have a reasonable question and answer session. Is that all right, Miriam?
That's fabulous. Thank you so much, Neil. That was very interesting to hear, and a warning, I think, across what we need to do with some of this. There's an interesting question in the chat from Carol, which kind of ties in with some of that, really, about where does the responsibility lie for if practices are receiving more data into records via self-monitoring. Are clinicians going to have to check through all and be responsible for contacting the patient if readings are a concern? So I don't know, Neil, if you'd want to have a go at that to start with.
Right. So if the data goes directly into the record and doesn't go into practice workflow, then that may never be seen, and the patient needs to be warned that that information may never be seen, and it needs to be clear to the patient that they shouldn't be posting information that might be critical. If the information is out of bounds, how is that filed into the record? And should out of bounds information not go into workflow? If all of the results go into workflow, how is the GP practice going to cope? So there are hazards around putting it into workflow and not putting it into workflow, basically. And the idea is whoever is creating the system needs to consider all of those aspects. There isn't a straightforward single answer to it, but the important thing is that you understand the consequences of what you're doing.
Yeah, thank you. I don't know whether if Nosheen is still there, she got some views on this, because I think this relates into the point you were making around change management and thinking about how some of these tools are used. Not sure if she's still with us because she had to. Oh, there you are. Great, thank you.
No, I agree. Sorry, a lot of what Neil said is exactly what a lot of the work that I do when I'm brokering these conversations has been around. So making sure that people know the responsibility. When we talk to a technology company, we make sure that they have highlighted any red flags, how they are going to circumvent those who are putting in readings that are for A&E or emergency services. So, and making sure those flagging is done at the beginning. So we actually had a meeting with a company, I'm not going to say who, but they had sort of a remote monitoring or remote consultation tool, talking through the patient through a number of questions, and only at the end did it sort of have the red flag to say, if you're suffering from chest pain or etc., go to A&E. And we said, no, put that at the front, because you don't want to waste this patient's time for 10 minutes filling out, you know, a form for you. And it's those little nuances that really do make a difference when you're, you know, talking to these companies. And that's kind of where we would help support as an AHSN. We wouldn't expect you as primary care doctors on the front line doing all this as well as seeing patients. You know, you want to have tools that have gone through that due diligence process, and that's why it's important to have someone kind of do that work for you.
Yeah,
and that's another good example, really. So what's a red flag for one patient is not necessarily a red flag to the same degree for a patient with sickle cell disease. And if you have a lot of patients with sickle cell, you need to be considering things differently from some practice in rural Northumbria, as an example. Yeah,
that's really interesting. And I would, there's a point which is disappearing off the chat at the moment, which was about the, oh, hang on, sorry, I need to go back because they're coming in thick and fast now. Somebody has said that you don't have the workforce in general practice in order to be able to do this. And I think both Sarah and Nosheen have provided examples where you're looking at how the HCA and the health coaches, etc., can actually support some of how these tools are used. And I think Sarah highlighted the need for having some sort of telehealth coordinator in order to be able to do that, which feels to me as though it fits in with what's going on in terms of the PCN rules. I don't know whether, Sarah, you have a view, and Nosheen.
Yeah, I'll jump in before Nosheen. I mean, we've used Telehealth with the on the Smart With Your Heart, and it worked really well. All the staff, though, that were on there, they had some level of experience of patient engagement, so they weren't kind of novices. So, and because it was a test bed, it was a secondment role. So one person was seconded from they're a discharge facilitator, so they were used to engaging with patients, and that was key with the role that we've just set up with the COPD. The telehealth is there, one, not just to do the monitoring, but that patient, encouraging the patient engagement, because what we tend to find is they might engage for a little while, but then motivation of the patient to engage with the digital tools goes off, and using the telehealth as a motivator, just ringing, see how you're doing, that actually just keeps the momentum going with the digital application.
Brilliant, thank you. Nosheen.
No, I was going to say the same, and actually, it's ironic that you mentioned Flow, because they actually were one of the companies we worked with, and we actually sort of help signpost where they might be most useful as a chat box. So, you know, they were offering services in multiple areas, not just heart failure, but it's understanding where it would be most beneficial in that process. So I think that's a great use case for them.
So did anything come out in terms of the international studies that you were doing, VJ, that kind of reflect on some of these? You're on mute, VJ.
Yeah, some of the features underpins some of what's been said, and they're common across, you know, internationally when you're using technology. But one of the issues he said is that when patients record data, they can sometimes choose their devices as well as have devices which are suggested by the healthcare providers. And what the idea is that people will make their choices about what they want to use, what they prefer. And as Neil said, it has to be personalized. But really, we want them to self-manage, self-care. And it's the point that we need intervention by healthcare professionals. And it's not the data, it's how it's going to benefit the patient, the people we're trying to help. And obviously make sure it doesn't overwhelm the healthcare providers as well, the practices, the hospitals. So this is part of the reason for this program today, to work this out. It's not easy, but the technology can probably help support patients to manage their own health and manage alerts to a point. And hopefully that will get better and better in time.
So it's really interesting what you've just said, because Carol has put something on the chat saying that she really wants to embrace some of this, but is quite concerned about the amount of work that might set off within practice, supporting patients as they get to use the systems. So I think it's all about the change piece again, and it's not just the change within the practice. It's the change for the patients as well. And it's actually thinking about, well, how do they do it? What things do we need to put in place in order to be able to support them through that? I thought it was really interesting, Sarah saying that she had a lot of the people on the heart one that you did were over 70, were 73. So actually, in some cases, age is not a barrier to some of this as well, but it's about the support perhaps that we're providing them, and which supports the practices and other professionals as part of this rollout. It's a multifaceted thing.
Yeah, definitely. And I think the other thing that, just to put in there, I think we reduced the number of patients because we were asking them to be able to use text messaging, but also the web-based. If we'd have actually just trialed it using text messaging, I wonder if we'd have more, but actually having the combination of the two, don't be put off by age, that's what I would say, because actually we did have 73 plus who were able to use text messaging and have, you know, access to the web, have iPads, and quite confidently would use them.
Yeah, I've been in a position where I've had much younger patients who had no internet access. So it goes back to, we need to be able to address those inequalities, but not necessarily make some assumptions. Alan asked an interesting question, which I think is sort of aimed at Neil, really. Is there a general mechanism for reporting problems, such as Neil has reported, and analogous to yellow cards or post-marketing surveillance? Neil, I don't know whether that should be directed to yourself.
There is a national reporting and learning system, which is meant to capture this kind of information, but it's not widely used in the health informatics arena, and it's not actively really monitored. So they come from various sources. We try to capture them and learn from them. And we do have generic hazard logs that we try to make available for each area as we come across them. But no, it's not like the MHRA. I mean, major problems like the algorithm problems of CHADS-VASC and QRISK that we've had historically have gone to the MHRA because they involve medical devices. But a lot of the other problems around, you know, the SMS messaging and the like, or the sort of failure of calculating average blood pressures, never make it down that route, unfortunately.
Okay, interesting. So I think there's one final question, or well, it's a statement really, which is from Saptarshi, and forgive me if I'm mispronouncing your name, which is about basically we need to remember that you still need to have a holistic approach to medicine, because you know you as clinicians, I'm not a clinician, you'll know yourself that you see things which when they come in the door, it's not just the data or the tools that are there. So I think that's quite interesting, but it's using some of these things to support you in that, isn't it, to provide you with the information and using the tools for what they're good at. And I think that ties in with what Nosheen was saying earlier. It's important that it's the appropriate tool, and that, you know, it's not a tool for a tool's sake. It's making sure that it's actually helping you to fix a problem. And you've got to see that in the system as a whole, i.e. the pathway. And I would say that perhaps the pathway might need to be contentious. The pathway might need to change slightly depending on what you're doing. It might suggest things, but others may have a different view. So Sarah has said, respiratory app we are piloting is COPD Predict app. Okay. I think other people are just interested in that. Thank you so much. I think we're just about finished and Nosheen has to leave. Thank you so much for, if I could just say thanks to the speakers, and thank you for your help and for your presentations. They've been really, really interesting. And I hope will be the start of a conversation that we can have. I was just going to put this up so that you can see, hopefully you can see this. So the group, as I said, thanks to all the speakers, save the date. It looks like our conference, for those who know us, we have a conference coming up in November. So we're going to be in Harrogate this year. And it's the 10th of November for the Education Day, which is free, and the 11th of November, which is the paid for conference. I've put up the link to the group so you can get on there. And if you want to speak to any of us or find out anything, then you can contact us on these emails. We will be sending out the recording to all of the people who've attended here today, and that should happen in the next week to 10 days. So I think without further ado, I can call this to a halt, and if that works. Have I forgotten anything? No.
Turn the recording off in a minute.
Yeah. Yes, we'll do. All right. Thank you all. Thank you for attending, and we look forward to seeing you all again.